This conference will now be recorded.
Hello. Hello.
Yes, ma'am.
Hello. వినిపిస్తుందమ్మా?
Yes, ma'am. Audible, ma'am.
వీడియో PPT.
Yes, ma'am. PPT కనిపిస్తుంది.
Oh. Okay. Twin pregnancies. It's also called as multiple pregnancy. Coming to the definition, simultaneous development of more than one fetus in utero is called as twin pregnancy. Incidence, the twins are usually, the incidence is 1 in 80. 80 is 80 pregnancies. That the incidence of naturally occurring monozygotic twins remains constant worldwide. That is 3.5 per 1,000 births. That is almost like 4 pregnant women per 1,000 births will have monozygotic twins. The incidence of twins is 1 in 80. When coming to the particularly in twins, it is of monozygotic, it is of 3.5 per 1,000 births, which is constant. Zygosity refers to the makeup of twin pregnancies. Usually 30% are monozygotic, 70% are dizygotic. You need to know about what is meant by zygosity and what is meant by chorionicity. Chorionicity is number of placentas in the womb, whereas zygosity is number of ovums, how it has divided, like number of fertilized ovums. Can you get it? Zygosity is number of fertilized ovums, whereas chorionicity is, it indicates the placental composition, that is number of placentas. There is a huge difference between zygosity and chorionicity, which you need to understand. Coming to the zygosity, usually in twin pregnancies, 30% are monozygotic and 70% are dizygotic. Dizygous and monozygous. This is how the picture tells you. See, dizygous is, okay, what do you mean by monozygous? What do you mean by dizygous? Mono itself is telling that it is 1. Di is 2. Dizygous is fertilization of 2 separate ova. We have earlier dealt with the definition of zygosity, which means fertilized ovum. Dizygous is fertilization of 2 separate ovum. That is, then they will have 2 different placentas, 2 different amniotic sacs. That is dichorionic, diamniotic. Whereas coming to monozygosity, it is splitting of single fertilized ovum into 2. If the splitting occurs in less than 3 days, then it will be dichorionic, diamniotic. If it occurs between 5 to 8 days, then it is diamniotic but monochorionic. If it occurs more than 8 days, it will be monochorionic, monoamniotic, or it might be after 12 days, it is conjointins. Why there is a difference between chorionicity and amnionicity in monozygous? Because when coming to dizygous ovum, 2 different ovums are fertilized by 2 different sperms, and they will become a fertilized ovum, then all your blastocyst and all, and which gets implanted in the womb. Thus they will have different chorionicity and different amnionicity. That means they have 2 different placentas, and amniotic is 2 different sacs. When coming to monozygous, why do they have, why do sometimes they have a dichorionic, diamniotic, sometimes they have monochorionic, diamniotic? Because here we need to discuss about chorionic and amniotic sac and when they are formed. Chorionicity is placenta. Usually, when does the placenta starts? It starts forming within 3 days and gets completed by 6 weeks and 6 to 8 weeks and takes over its function. So, if a splitting of ovum occurs before the before the placenta has started, that is less than 3 days, then it is dichorionic diamniotic. If the splitting occurs after 3 to 5 days, then it is monochorionic diamniotic. If it is occurs between 5 to 8 days, then it is monochorionic monoamniotic. Usually after 8 to 12 days, it is conjoined twins. See, monochorionic, this is a picture showing monochorionic diamniotic. Monochorionic is single placenta. See, 1, 2. Two placenta, same placenta, two different cords are there. And diamniotic. Amniotic is amniotic sac in which the babies are. There are two lines in between, yellow color lines with an intervening chorion. It means that they have the separate sac. It means this embryo is formed. These embryos are formed between 3 to 5 days. That is when chorion is placenta is already formed, after which they have divided. So placenta remains 1, after which they have divided. So amniotic remains 2. That is monochorionic diamniotic. What do you understand by this ovum and a sperm in it? This is monozygous. Because here only one sperm has penetrated one ovum, fertilized one ovum, but resulted in twin pregnancies. So it is monozygous. See, this is a clear picture. You need to understand how it is formed. This is the two cell stage. That is, it might be a single ovum which has, which has been fertilized, in which it develops into two separately, and then chorionicity, amnionicity develops separately, and then forms dichorionic diamniotic. But if the two cell stage division has not occurred between first 4 days and division, and it has grown to 8 cell, then blastocyst, and then it has divided, then it might result in a monochorionic diamniotic, monochorionic monoamniotic, monochorionic monoamniotic conjoined twins. Here you need to remember, see, if it is a dichorionic and diamniotic twin pregnancies, that means there are two babies, two different placentas, and two different amniotic sacs. It means it might be from two different ova fertilized by two different sperms, or one ova fertilized by one sperm, but the separation has occurred at an early 2 to 8 cell stage where it has resulted in dichorionic diamniotic. But if you have seen monochorionic diamniotic, or monochorionic monoamniotic, or monochorionic monoamniotic with a conjoined twins, it is 100% from a single ovum fertilized by a single sperm. Did you get this? There are two different things. Diamniotic dichorionic might be a result from two different ovums fertilized by two different sperms, or single ovum fertilized by one sperm, but division of ovum, fertilized ovum into two has occurred in the early stage. Then these two are conditions where we might get a dichorionic diamniotic. If we see a diamniotic dichorionic, or other than this, any other scenarios such as monochorionic monoamniotic or conjoined twins, then that pregnancy is a result from monozygotic twin separations or divisions. These are the main difference between the diamniotic dichorionic, monoamniotic monochorionic, or the rest versions. That is difference between monozygotic, dizygotic. Zygosity refers to the ovum. Chorionicity refers to the placentas, number of placentas. See, this is a picture where two worms are fertilized by two different sperms, resulted in Dichorionic. How we will say dichorionic? What we have discussed, chorionicity is number of placentas. So in this picture, we have seen two different placentas. And then amniotic. How we have told amniocity is number of amniotic sacs in which baby dizygotic. Monozygotic twins and dizygotic twins. Usually identical twins will be there because monozygotic is why you need to understand why there will be identical twins and why there will be gender same. If you are cutting a cake into two pieces, then both the cakes are of same color, same variety, but two different pieces. So remember that. Then monozygotic twins is making half of fertilized ovum. So then when you are making a half of fertilized ovum, or when there is a division of fertilized single fertilized ovum, do you think one ovum, I mean one part will be female, the other part will be male? No. When there is a division, there will be a division of all the chromosomes also. So if one part has XY, the other part also will have XY only. So they will be identical twins and they will all share the same features because you are cutting a single fertilized ovum. So they will be identical twins and always of same gender. Everything will be same when you see a monozygotic twins. That is because one full cake is being cut into two pieces. So everything, see, okay, let me explain you have taken a cake and you have cut into two halves. Do you think one half will have more sugar, the other half will have less sugar? No, both will be of same sweet because batter of the cake is normal, same, which you have prepared. So when you when a pregnancy has resulted from a monozygotic twins, then remember it has been a division of single ovum which is fertilized by single sperm. Then what happens? The gender will be same, they will be identical, the blood group will be same, appearance will be extreme, I mean mostly similar, genetic code will be nearly identical. But when coming to dizygotic twins, what we know about dizygosity, it is two different ovums has been fertilized by two different sperms. So they will be fraternal twins. Usually binovular is the same, two different ovums. Usually here gender will be different because the same think monozygotic twins are division of a single cake. Dizygotic is division of two different cakes. In two different cakes, the batter might not be the same batter. So here everything will be different. Like genders may not be different, I mean may not be the same, like two males, two females may not be the same, blood type may be different. Usually the dizygotic twins cause will be hereditary or an result from IVF pregnancies because we implant more embryos, there will be more chances of twin pregnancies in IVF. Appearance, usually they won't be similar, like monozygotic twins. Twin to twin transfusion syndrome is low, very less, because here two different placentas will be and two different sacs will be. Did you get this? The difference between the monozygotic twins and the dizygotic twins. This is very important for you in this stage. Coming to the next definitions, it is superfetation and superfecundation. So when you are talking about multiple pregnancies, you need to know the definition of multiple pregnancy, incidence, What do you mean by monozygotic? What do you mean by dizygotic? That is, what do you mean by zygosity? What do you mean by chorionicity? What do you mean by superfetation? And what do you mean by superfecundation? These are the 6 definitions we expect you to answer when you are presenting any twins case. Coming to the definition of superfetation, it is fertilization of 2 ovum at an interval as long as or longer than a menstrual cycle. That is superfetation. Whereas superfecundation is 2 ovum within the same cycle but not by the same coitus. Did you get the difference between fecundation and fetation? See, fetation is already it has a baby in the womb. Super is more than that. So fertilization of 2 ovums not in the same menstrual cycle. Next, superfecundation is fertilization of 2 ovums in the same menstrual cycle need not be with the same coitus. That is, if a pregnancy has been resulted from a superfecundation, both the babies will have similar age because in a same cycle they have been fertilized. So usually they have the same age or a 1 week difference. Whereas coming to superfetation, it need not be of same age because patient is not conceiving in the same menstrual cycle. Suppose example, if a patient has come to you of 7 weeks pregnancy or 8 weeks, think it is 8 weeks of pregnancy. She doesn't know that she is pregnant at 8 weeks. Then you have done a scan which has been showing a single live fetus. You have sent her home saying normal, prescribing all your normal medications and explaining her the do's and don'ts. Then she has come to you next week or next month or after 6 weeks. Then you have done a second scan. Surprisingly, if you see 2 different embryos with 2 different ages, like weeks of gestation, 2 different weeks of gestation, first thing it should come into mind is whether we have missed the second fetus or embryo during the first scan, or it might be a result from superfetation where the first fetus will be of 8 plus 6, 14 weeks gestation, and the second fetus will be of 5 weeks gestation. Then you need to think that it might be a resulted from superfetation. Did you get this? Superfetation, the siblings may not have the similar age. Whereas in superfecundation, they have a similar age because they have been conceived in the same menstrual cycle, but they might get conceived with 2 different coitus. That is the difference between superfecundation and superfetation. Coming to twins, then you need to know the difference between superfecundation and twins. In twins, it is of same coitus. If it is of 2 different coitus, then it is result from superfecundation. These are the definitions. Twin pregnancies, zygosities, chorionicity, superfecundation, fetation. Coming to the predisposing factors of twin pregnancies. Increased maternal age. If the age of the mother is more than 35, no more chances of her going for an infertility treatment or getting stimulated, which might result from or imbalance in the hormones might result from a twin pregnancy. Increased parity because more release of ovums. History of family of twins, mostly from the maternal side, not the paternal. Maternal is from the mother, paternal is from the father. Use of ovulation induction drugs, which is a result of multiple, is very common. Due to due to the ovulation, multiple ovums get released and might get fertilized by the sperms. Use of infertility treatment. Racial variation also has a role in twin pregnancies because usually we see high twins in Nigeria and South Africa because they have a consumption of having yam, which is a phytoestrogen, which is like our ovulation drugs, which stimulates a super ovulation. Mostly they are monozygotic. Constant incidence of monozygosity is 3.5 per 1000 births. age relate how age is a plays a role in twins is the higher the age, the dynamic hormonal changes in the pituitary gland and ovary thus results in a twin pregnancies. Or how oral contraceptives plays a role. The higher incidence of dizygotic twins within 1 month of discontinuation of OC pills, but not during the subsequent months because increased concentration of pituitary gonadotropins. What do you mean by ART? ART is uh, hello. ART is assisted reproductive technology, that is all your IVF, that is infertility treatments or in vitro fertilizations and all, which results from because of superovulation by the drugs and all. We see usually twin multiple pregnancies after an ART. Not only that, due to the when we are transferring the embryos, we usually transfer 3 embryos per cycle, where it might result in a multiple pregnancies. What are the maternal and fetal effects of multiple pregnancies? Maternal effects. It is a physiological adaptations where the blood volume increases. More 20% increase in the maternal cardiac output is seen. What are the maternal risks? There will be increased symptoms of early pregnancy. What are normal symptoms in the early pregnancy? That is your first trimester. Patient usually complains of nausea and vomiting. Why this is why the patient will have nausea and vomiting? Due to the beta hcg hormone, which is produced from, where does beta hcg gets produced? Hello, hello, వింటున్నారా అసలా? Hello.
Yes, ma'am.
బీటా హెచ్సిజి ఎక్కడి నుంచి ప్రొడ్యూస్ అవుతుంది?
Placenta.
ఇంకా refined answer. Beta, due to its beta hcg production, increased symptoms will be in the early pregnancy. Increased symptoms in the early pregnancy, that is nausea and vomiting. Vomiting. If beta hcg usually gets produced from the placenta, if there are two different placentas, there will be more production of beta hcg. Thus the mother will have more nausea and more vomiting. Anemia is one of the maternal risk factors. Because of supplying blood for the two fetuses, there will be more hemodilution. Complications of pre-existing cardiac diseases. If a patient, if the mother is already known cardiac diseases, her pregnancy will worsen the cardiac disease, because we know rule of 5, where there will be alterations in the hemodynamic status of the mother, and due to twins it will be more increased percent, so there will be a chance for complicating the cardiac diseases, worsening the cardiac disease, more chances of UTI, more chances of hypertension and preeclampsia, more chance for gestational diabetes mellitus. There are increased chances of polyhydramnios, preterm births, operative vaginal birth, cesarean section, and postnatal illnesses. Coming to the fetal risk, we see vanishing twin, malformations, chromosomal anomalies, conjoined twins, acardiac twins, and single fetal demise. The other complications are twin to twin transfusion syndrome, preterm labor, PPROM, cerebral palsy, selective fetal growth restriction, and growth discordance. Congenital abnormalities, usually coming to the congenital abnormalities, usually monozygotic twins will have more congenital abnormalities than a dizygotic twins. Unique in twin pregnancy, those are conjoined twins. If the division has occurred after 8 to 12 days, then it will be resulting from a conjoined twin. Malformations due to vascular events are common, that is following a demise of other twin, microcephaly, hydrocephalus. Deformities from intrauterine crowding, that is foot to hip and skull, that is lack of space in the uterus because of two babies. Increased early pregnancy loss is usually seen in twins, which constitutes to 12%. Mortality of one or both the fetuses in first trimester is usually common, which is called vanishing twin in 5% of cases. Vanishing twin syndrome occurs when a diagnosis of a twin pregnancy is made sonologically and in the first trimester, then it is called vanishing twin. Whereas fetus papacious is one twin dies at an early gestation, and you come to know after the delivery by delivering after the delivery. Single fetal demise of vanishing twin constitutes to 2.4 to 6.8% of twin pregnancies. Identification of two viable fetuses in the first trimester, followed by an IUD of the one of the twin in a later point, is a diagnostic criteria for single fetal demise or a vanishing twin. It is like this: monochorionic twins suffer 18 times higher than dichorionic. Here, the yellow round is showing the vanishing sac. The other, whereas the other, don't worry, mummy is strong. That sac is gestational sac is showing the single fetus, which is growing healthily. In a monochorionic twin, there is a shared circulation in the placenta with different anastomosis, that is arterial to venous, venous to venous, and arterial to arterial. Any of these abnormalities results in a twin to twin transfusion syndrome or twin to twin transfusion syndrome. Aberrant twinning mechanisms. This is of zygosity. If both the separate symmetrical conjoined twins, acardiac, these are the different varieties of your monozygous twins. Both can be separate and healthy, or both can be healthy but joined, that is called conjoined, or one can be normal, the other will be abnormal. One will have a heart, the other will not have a heart, which is called acardiac twin, or twin reversal arterial perfusion syndrome, TRAP. Or one might be a parasite, the other will be normal, that is called external parasitic, or fetus in fetu. Fetus in fetu might be your 2-mark questions. Coming to the separate and conjoined, they are symmetrical. That is why there is a division of symmetrical. Asymmetrical is based on the size of the fetus. In symmetrical, that is separate and conjoined, both the babies will be of similar size. Whereas in asymmetrical, one will be big, one will be small. That is why it is divided into symmetrical and unsymmetrical. In asymmetrical, all your trap, external parasite, fetus, and fetu comes. This is a twinning mechanism in monozygous. Coming to the twin to twin transfusion syndrome, it occurs in a monochorionic twin pregnancies. Occurs if there is a shift in the net blood flow between the two fetuses, which results in hypervolemia in one fetus and hypovolemia in the other. This is a diagram showing a normal small fetus and a normal sized fetus. A small sac, a big sac, very low amniotic fluid, and big amniotic, more amniotic fluid. Donor twin will be hypovolemic, oligohydramnios, and anhydramnios with an empty bladder. The red one in the baby, it is showing a bladder. Growth restriction will be there, that is intrauterine growth restriction. It will be, baby will be of restricted baby, that is less than the weeks of gestation. Abnormal Doppler will be seen in uterine artery. This is twin to twin. These are the other photos showing a correctly twin to twin. Donor will be thin, empty bladder, hypovolemic, that is and will not have amniotic fluid more, whereas the recipient will have polyhydramnios. The twin to twin is resulted from arteriovenous anastomosis and diversion of the fluids. In when you see a twin to twin transfusion syndrome, like in on ultrasound, you need to know what are the different stages of twin to twin. Usually we have five stages. In the first stage, imbalance of amniotic fluid is seen on ultrasound. Less than 2 centimeter around the donor twin and more than 8 centimeter around the recipient twin. That is, centimeters is your amniotic fluid content. That is single pocket content. More than 20% of difference in the size is seen between the two fetuses. That is, when you measure the fetal weight, more than 20% difference of the two fetuses will be seen. When these are all there, you need to think about twin to twin transfusion syndrome, and they are under stage 1. When coming to stage 2, bladder of the donor twin will never be visible and doesn't fill urine during the ultrasound. Coming to stage 3, abnormal Doppler in the donor is seen. When the stages are increasing, there you will see a donor twin. The weight of the donor twin will be less. The bladder will not be seen. There will be Doppler abnormality in the donor twin. Stage 4 will be all your hydropic changes in the recipient. Ascites, pericardial effusion will be seen in the recipient because excess of fluid into the other twin, it is like a drowning, suffocation. And stage 5, demise of one twin will be seen. This is twin to twin transfusion syndrome. Usually the management of twin to twin transfusion syndrome is observation through frequent ultrasounds. When you diagnose a twin to twin transfusion syndrome, you need to go either for fetoscopic laser photocoagulation, usually around 16 to 26 weeks of gestation, or amnio reduction removes the excessive fluid from around the larger twin, that is a recipient twin, reducing amniotic pressure, reducing the risk of preterm. This is a serial amniotic reductions where you do amniocentesis and removal of excess fluid from the recipient one, or do a laser photocoagulation where the anastomosis is cleared. Coming to the monoamniotic twins, which is a result from the late embryonic splitting stage, that is bilaminar germ disk. 1.5%, 1 to 5% of all the monozygotic twins. Perinatal mortality is seen 30 to 70%. Diagnosis at 8 weeks by delineation of one of the placenta. Coming to the next, twin reversal arterial perforation, which is seen in 1% of monozygotic twins. They have a monochorionic placenta with vascular anastomosis that can sustain a life of an acardiac twin. Here there will be monochorionic placenta, that is single placenta. Twin 1 will not have a heart, but twin 2 will be normal. So from twin 2, blood will be supplied to twin 1. It's also called as acardiac twin. The other is twin anemia polycythemia sequence. This is usually seen in 20 monochorionic diamniotic twins. More commonly occurs after fetoscopic laser coagulation of twin to twin transfusion syndrome. Large hemoglobin discrepancy will be seen between the two twins. Anemia in a donor twin and polycythemia in the recipient twin. Doppler ultrasound will give you a diagnosis for TAPS. That is like mid-cerebral artery peak systolic value will be increased. It develops in absence of severe oligo or polysequence. Postnatally, the intertwin hemoglobin difference will be 80 gram per liter. Next is our Siamese twin or conjoined twins, usually seen in 1 in 200 of monozygotic twins. To 1 in 68,000 births. Anatomically, classification is based on the fusion or presence division of monozygotic occurs after 8 to 12 days. But that is occurs when a single embryo incompletely divides between 13 to 15 days after fertilization. The diagnosis is usually ultrasound in the abdomen. When you do an ultrasound, you see a bifid appearance of the fetal pole. This is a diagnostic criteria for diagnosing conjoined twins. That is bifid appearance of a fetal pole, 4 vessels in the umbilical cord. Heads will be usually at the same level because they will be conjoined at some or the other point. So if one moves, the others also will move. The other baby also will move at simultaneously. So head will be of same level, no change in fetal position relative to each other. Extended position of spines will be seen because they are attached. These are the different varieties of conjoined twins, how they occur. That is ventral connection or dorsal connection. If it is a ventral connection, then it might be omphalophagus where intestines, thoracophagous where thorax is attached, or cephalophagus where head is attached. If it is caudal, then it is ischiophagous where both the ischiums are attached. If it is lateral, then it might be a paraphagus or paraphagus disproportus or paraphagus dicephalus. When it is a dorsal attachment, you can see that is it might be a craniophagus, rachiophagous, or pyophagus. Buttocks, back, or head. These are the different varieties of conjoined twins based, and they are differentiated into on the type of attachment, that is a ventral or dorsal. On based on ventral also, where it is exactly attached, it is again divided into omphalophagus, thoracophagous, cephalophagus, craniophagus, rachiophagous, and pyophagus. These are different babies which have delivered and photographs. First is the ischiophagous, next is the omphalophagus, thoracophagous, and pyophagus. Next, coming to next risk of twin is fetus in fetu, which is an abnormal embryogenesis in a monozygotic pregnancy. Fetus is enclosed within the body of other normally developing fetus. The growth of the fetus in fetu initially parallels that of its twin, but stops abruptly either because of vascular dominance of the host. Diagnosis. It is mostly by clinical. Uterus is larger than the period of gestation. 3 poles should be felt. Hearing of heartbeat. 2 separate places will be seen, separated by a silent area. 2 observers listening simultaneously. When you do an ultrasound, you see dichorionic, diamniotic, and hydramnios will be seen. Gestational age determination. CRL is superior to the use of menstrual dates. 14 to 25 weeks. Head circumference is reliable for dating. CRL discrepancy of 10 mm. Significant growth discrepancy is seen. Chorionicity determination. First trimester, usually you have to, for number of placentas, you need to do a ultrasound within 14 weeks of gestation. Then your chorionicity accuracy will be more. That is, we need to know whether it is a single placenta or 2 placentas, which can be confirmed by histology at birth. Usually, the lambda sign is first described by Peppernick, which indicates it is a dichorionic placenta, that is 2 placentas. This is the lambda sign or a twin peak sign of dichorionic pregnancy when you see under a ultrasound. That is a triangular projection extending from base of the intertwin membrane in early dichorionic pregnancies with a single fused placental twin peak sign is seen. Monochorionic, absence of lambda sign to the finding, and T sign is usually seen. Dichorionic, 2 placentas with the lambda sign, and the monochorionic, only 1 placenta with a T sign. These are the diagnostic criteria to know the number of placentas, and when you have diagnosed and twin pregnancies. Now you need to know how you are labeling the twin, that is twin 1, twin 2. Each fetus within the twin pregnancies can be oriented at 11 to 14 weeks ultrasound. The fetus contained in the gestational sac closest to the maternal cervix is designated as twin 1. The relative orientation of the fetuses to each other is then defined as either lateral or vertical. This is how it is. This is a diagram which is showing. In a first diagram, the down one will be twin 1, the up one will be twin 2. If they are lateral, then you need to you need to differentiate and name the twin side right and left. Discordance, fetuses of multiple gestations does not grow on the same rate. There will be slight discordance in the growth will be seen, which is obviously measured. I mean, when you do an ultrasound, according to their fetal weight and all, you will come to know there might be a discordance in those babies, which is normal if it is slight. But if there is a absolutely different birth weight differences between smaller and larger twin, then you might name them as fetal discordance. The definition assigns same degree of discordance to a twin pair of 3000 to 2. The pen. Discordance is diagnosed if difference in the inter-birth weight, twin birth weight is more than 20%. That is, if if twin 1 is of 3 kgs and twin 2 is of 1.5 kgs, then you need to name them as fetal discordance, because the weight is more than, difference between weight of both the fetuses is more than 20%. Or if there is a difference of more than 20 mm of in abdominal circumference, or if there is a difference of biparietal diameter of more than 8 mm, or then you need to you need to name them as twin discordance. Twin discordance is usually the result of twin to twin transfusion syndrome. Twin weight discordance is associated usually with any structural malformation. Suppose you have done a scan of 30 weeks gestation and you have seen the baby weight. If one is 1.4 kgs, the other is of 700 grams, then immediately you need to know, you need to think of why the growth discordance is between the two fetuses. If you have seen one of 1.2 kgs and one is of 900 grams, you need not worry, because they won't come under fetal discordance, because according to our definition, the fetal weight should be of more than 20% difference. So when you have seen and you have diagnosed of weight discordance, you need to know why there is weight. Immediately you need to go for and think of any structural malformations, stillbirths, IUGRs, preterm deliveries, and might result from all these things. The management of twin pregnancies. You need to do first pre-pregnancy counseling, the counseling of ART couples, because we have discussed that ART is one of the, that is assisted reproductive technology, is one of the etiology of twins, because there will be super ovulation, super stimulation, or transfer of multiple embryos during the IVF stimulations. So you need to clearly explain them that might result from a multiple gestation, multiple pregnancies. Other thing, preconception of folic acid should be explained to them. Antenatal management, nutrition. If we nutrition should be doubled, because metabolic rate of the mother is usually 10% higher than in a normal pregnancy. Daily recommendation of calorie intake should be increased to 40 to 45. You need to suffice both the fetuses. All the diet should be of 3 meals, 3 snacks, because more chances of gestational diabetes. Frequent antenatal visits should be explained. In uncomplicated monochorionic diamniotic pregnancies, it is of 9 appointments. If it is uncomplicated dichorionic, if it is of 8 appointments, which is of like a normal pregnancy. 75 mg of aspirin daily from 12 weeks until birth if they have a high risk factor, such as if they in their first pregnancy, any pregnancy loss, if the age of the mother is more than 40 years, of pregnancy interval is more than 10 years, BMI is more than 35, any history of preeclampsia, then you need to start them with 75% of aspirin. Next comes your antepartum fetal surveillance. Non-stress test and biophysical profile has to be done to the mother, so that you can You can name them from complicated and uncomplicated if any things are there. Serial ultrasound assessment should be done. Usually we see ultrasound once in 2 weeks from 16 to 12 weeks until 24 weeks. Prediction and prevention of preterm must be your major criteria goal, because cervical length at 22 weeks has been shown to be a predictor for preterm labor and delivery. Cervical length, if it is less than 1.5 centimeters at 22 weeks, usually they deliver before 34 weeks. So level should be checked for to avoid preterm if the cervical length is less than 2.5 centimeters. So you need to think whether the womb and the cervix might weigh, whether they are capable of managing or weighing both the fetuses, and you need to go for cervical ensaccage. For preventing a preterm labor, you need to go ask for bed rest, tocolysis, progesterones. Usually the incidence of preterm in multiple pregnancies is most common. Cervical ensaccage is not is usually, they say it is not effective, but it is like a benefit out of the risk. Fetal growth and well-being assessment should be done. Serial fetal heart rate, serial ultrasound fetal biometry has to be checked for. Timing of the delivery, it depends upon the twins. Perinatal mortality of twins higher after 38 weeks. So we need to deliver twin pregnancies earlier than a singleton. In dichorionic twins, if it is uncomplicated twins, you can wait till 37 completed weeks. Complicated twin, timing should be based on the parameters of the healthy twin. Usually they say if it is a if it is a dichorionic twin and uncomplicated, wait till 37 completed weeks. If it is a monochorionic uncomplicated, wait till 36 weeks. If it is a complicated, usually they say timing should be based on the compromise of the fetus. If it is triplets, it is 34 completed weeks, that is 35 weeks, 0 days. Usually the term varies when number of pregnancies increases. Usually we say 38 weeks term for a singleton pregnancy. You need to minus 2 weeks for a when one more fetus is increased. That is 36 weeks. If one more twin is increased, that is one more fetus is increased, that is triplets, then their term will be 34 weeks. That is in singleton, term will be 38 weeks. In twins, it will be 36 weeks. In triplets, it will be 34 weeks. Labor and delivery, route of the delivery depends upon the type of the zygosity and number of fetuses present and their lie. If it is cephalic, 40% chance. Cephalic breech, cephalic transverse, and breech are the common presentations we see in a twin pregnancy. If it is twin A vertex and twin B vertex, usually they can deliver vaginally. 70% deliver vaginally and 20% need cesarean delivery. Approximately 10% unexpected event may occur after the delivery of twin A, which results in the cesarean of twin B. Twin A vertex, twin B non-vertex, vaginal route can be tried. External cephalic version of the second twin should be done, and breech extraction if the version fails. If it is breech, go for an cesarean section. Twin A non-vertex and twin B others, risk of fetal entanglement will be there, so cesarean section is best. When comes to monoamniotic twins, possible complications should be explained. Most will have cord entanglement. Best to deliver electively by cesarean section at 32 weeks or after corticosteroid administration. Labor and delivery intrapartum management should be managed, like you need to prepare everything. You need to have one side OT ready because of any complications during the delivery of any twin. You need to immediately shift her to OT for a cesarean section. Trained obstetric attendant should be there. Continuous electronic monitoring of the fetal heart should be there. Blood should be kept ready because these twins will have more chance of PPH. Ultrasound should be kept near so that you can deliver by seeing the positions and descent of the fetuses. Anesthesia team should be ready. Neonatal resuscitation pediatrician should be ready. Analgesia, anesthesia, labor analgesia is ideal, provides excellent pain relief, can be rapidly extended cephalad. Labor induction can be started. Oxytocin alone is safe in twins. Controlled ARM should be done if it is over distension, hinders big distension, so that there will be no chances of cord prolapse. Second twin, if the longer the interval, the greater the risk of hypoxia. So after the delivery of the first twin, palpate the abdomen to ensure the fetal lie. Ultrasound, do an ultrasound for the confirmation. If needed, go for an external version if necessary. If non-cephalic, internal podalic version or breech extraction can be done. If non-engaged head or version, total breech extraction can be done with the starting oxytocin. On the return of contraction, second bag should be ruptured within with the twin in an uncorrected position. If labor not resumed within 10 minutes of delivery, after the first twin, oxytocin infusion, amniotomy, and delivery of the second twin should be done. Usually they say inter-twin delivery time should not exceed more than 30 minutes because there will be more chances of fetal distress in the second twin. If general anesthesia is necessary in a course of delivery of first twin or second amniotic sac at once, there has to be inserted to perform internal podalic version. Placenta should be checked after the second twin. After the delivery of the first twin, cord is divided between the two clamps. For the second twin, 3 clamps are used, leaving a double clamp on the side of placenta, which gives you an identification of a placenta of which fetus. When you see a single single clamp of the placenta, that will be of twin 1. If there are 3 clamps, then it will be of twin 2. Risk of PPH will be there, so you need to be cautious. Active management of third stage labor should be implemented, such as giving 10 units of oxytocin IM, control contraction. If your uterus is not contracted well, uterine massage, give methyl ergometrin, that is your methergine 0.2 mg IV, oxytocin start drip, continuous oxytocin infusion for 3 to hours at 30 drops per minute. Postnatal counseling should be clearly advised, such as encourage breastfeeding for both the fetuses. Postnatal depression is higher in these, risk is higher in these women. Offer longer in a patient stay. Provide adequate contraceptive advices for the second pregnancy. This is how you have you see a twin pregnancy delivery. When you This is a clear idea of all your twin pregnancies. You need to keep in mind that when you see a similar sex of two twins, then it might be a resulted from a monozygotic division or a dizygotic by fluke. But if you see two different sex of twins, then it is definitely of a dizygotic. Did you get this point? You need to clearly understand, when you see two boys of twins, then it might be resulted from monozygotic or dizygotic. But if you see a boy and a girl in a twin, then it might be 100% of dizygotic. This is a clear view of all your twin pregnancies. Here you might expect a question of 2 marks is superfetation and superfecundation. Or if it is a short answer, you might get a question from twin to twin transfusion syndrome or TRAP, or twin reversal of arterial perfusion. And when we ask you for Viva, you need to know the definitions. What do you mean by zygosity? What do you mean by chorionicity? What do you mean by definition of superfetation, fecundation? What do you mean by monozygosity? What do you mean by dizygosity? That's and labor management of twin pregnancies might be a short answer. This is a total proper view of all your twin pregnancy entire topic. Any doubts? అసలు విన్నారా? హలో, roll number 40 K Pavan. Yes ma'am. K Pavan
Yes,
అంటే
ma'am.
అమ్మాయి ఉంటాయి. హలో,
Ma'am.
జైగోస్టీ డెఫినేషన్ ఏంటి?
Number of fertilized ova.
విన్నావా?
Yes, ma'am.
రోల్ నెంబర్ 110 సాయి కృష్ణ. లేడా అసలు క్లాస్ లో? రోల్ నెంబర్ 110 సాయి కృష్ణ. ఏవి సూర్యకుమార్. శ్రీచరణ్. హలో 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 పంకజ్ రాయపురెడ్డి. హలో ఎవరు మాట్లాడలేదేంటి? వినిపిస్తుందా వినిపించట్లేదా? హలో సంజూష. సంజూష సరే. Thanks for your patience. I have completed the topic. Any more doubts?
No, ma'am.
ఇప్పుడు మాట్లాడింది ఎవరు? అంటే అసలు మీరు ఎవరు లేరా? జస్ట్ ఆన్లైన్ పెట్టి వెళ్ళిపోయారా? హరీష్ రాసల, రేష్మ, అజయ్, అన్వేష్, దివ్య, మేఘన, నాగసాయి వీళ్ళెవరు లేరా? సరే అమ్మా, మీ ఇష్టం. ఓకే, గుడ్ డే, బాయ్ అమ్మా.